Welcome to this TCTAP 2022 session on structural heart disease. This is an abstract session. So today we have speakers from different parts of the world. I'm the moderator, and we also have Dr. Wei Hin. He is now busy for some work, and he may join us later on. And we have Dr. Leong Zai. And for panelists, we have Dr. Ai Hong Ko, Dr. Sunsuke Gupo, myself, and Dr. Wojciech Wojciechowski. So first, we will start our first talk to be delivered by Dr. Amr Mansour from Egypt. The topic is biatrial geometrical changes following secundum ASD closure using MRI and the effect on electrical changes. So first, may I welcome Dr. Mansour?
Yes, hello.
Hello.
It's my pleasure on behalf, hello. It's my pleasure to present our work on behalf of my colleagues in this meeting and in this session. Our work is titled Biatrial Geometrical Changes Following Secundum Atrial Septal Defect Closure Using MRI and Their Effect on Electrical Changes. I have nothing to disclose. Chronic atrial stretch caused by ASDs result in atrial electrical remodeling, which manifests itself as a prolongation of P-wave duration. This has been proposed to be a substrate for arrhythmia later on life. So we decided to study the atrial geometrical and volumetric change 6 months after percutaneous and surgical closure of secundum ASDs by MRI and compare the effect of these two methods of closure on the B-wave dispersion. All the patients had 12-lead surface ECG that was recorded on 50 millimeter per second speed and the standard amplitude 1 millivolt per centimeter before and 6 months after closure of the secundum ASD. B-wave duration was defined as a distance between the junction of the baseline with the point of the earliest and latest P-wave electrical activity. The longest P-wave was noted as P-max and the shortest was noted as P-minimum on the 12-lead surface ECG. We defined the B-wave dispersion as a difference between the maximum and minimum recorded B-wave duration. We also had a CMR study for all patients before closure of the defect and 6 months after. We used a 1.5 Tesla MRI scanner and we had the acquisition of the SSFP ECG gated sequences in the 2, 3, and 4 chamber views. We traced the left and calculated the left atrial volume by manual tracing of the endocardial contours in the 2, 3, and 4 chambers. We excluded the left atrial appendage and pulmonary vein from our calculation. Longitudinal and transverse diameter were measured in the 2 and 4 chamber views. The maximum diameter and volume were measured in both the 2 and 4 chamber views, and the same method was used to calculate the maximum and minimum volume of the right atrium. However, the right atrial appendage was included in the right atrial measurement. This figure shows the endocardial tracing of the left atrium and measurement of the longitudinal vertical diameter. And this is the measurements of the right atrium, and we included the right atrial appendage as here in this image. This is the 4-chamber view before and after closure of one of our patients. We had a 30 adult patient with isolated secundum ASD. 15 patients had transcaster ASD closure and 15 age and sex matched group had surgical closure. The majority of our patients were female under the age of 40 years. This table showed that there was no significant change in the B-wave maximum P-wave duration and minimum P-wave duration and P-wave dispersion before and after closure in both surgical and device arms. This slide can show that the voltages of the right and left atrium has changed significantly before and after closure. We can conclude that biatrial electrical changes in the middle age patients with isolated secundum ASD did not improve 6 months after percutaneous and surgical closure, despite significant change in the atrial volume and geometry. This indicates a poor correlation between the mechanical and electrical remodeling at intermediate term follow-up, which was in our study 6 months follow-up duration. Thank you.
Thank you very much for your presentation. So the discussion is now open to the panel. And do you have any question and comment on this abstract? So can I ask, so what is the clinical implication when you have this finding? So would there any change in the clinical practice? For example, after closures, you will actively change your drug regime, or what is the clinical implication with these findings?
The clinical implication of this finding is that it is well known that closure of secundum ASD does not guarantee absence of future development of arrhythmias, especially atrial fibrillation. It is well known that, and in our practice, we close the defect because it's causing significant shunt and significant volume overload on the right side. But I cannot guarantee that this will abolish the risk of future development of arrhythmia, especially, of course, on adult patients. We are not sure closure of secundum ASD at a younger age, in pediatric age group or at earlier age, would result in better electrical remodeling that would accompany the significant mechanical and volumetrical and geometrical change after closure of secundum ASD or not. But this was not in our study. We studied these electrical changes in adult patients. Might be closure of the defects at earlier age would result in more significant electrical remodeling, but this needs a separate study.
Thank you.
Thank you.
Do you check with CMR at only a 6 month follow-up? How about the longer follow-up, longer term follow-up? For example, 1 year or 3 years or 5 years? How do you think?
Actually, we are following our patient now after the end of the study for longer term follow-up results, but we did not complete the first year yet. But we are planning to longer follow-up, do long-term follow-up of our patient and see the effect of the delayed, if there will be a delayed or further, might be the electrical change might be delayed, like the mechanical effects will be affected first and the geometrical change will be affected first and the electrical change might be delayed.
Yes.
And we will see the long-term follow-up of the patient. That's what we are doing now.
Thank you.
Yes, that's a very good point, because sometimes it takes quite a long time for changes to develop, and it would be good if you can report to us later on the updates and maybe possible longer follow-up data. So let's move to the next talk. Thank you. So the next talk will be from Dr. Netaporn Sangritaiken from Thammasat University Hospital, Thailand. So moving from ASD now, we go to aortic valve. The topic is short-term efficacy and safety outcomes of standalone balloon aortic valvuloplasty. Registry from Thammasat Heart Center, Thailand. So may I introduce Dr. Sangritaiken from Thailand to give us the abstract contents.
The topic of my presentation is short-term efficacy and safety outcome of standalone balloon aortic valvuloplasty. Registry from Thammasat Heart Center, Thailand. We don't have a conflict of interest. Severe aortic stenosis is one of the common and serious valvular problems. Currently, the mainstream treatment for symptomatic severe AS are surgical aortic valve replacement and transaortic valve implantation. Balloon aortic valvuloplasty or BAV has been used a bit procedure, rescue therapy and palliative therapy. However, in Thailand, there are limited data in terms of feasibility and outcome of BAV. Previous study showed 30 mortality after BAV was 10 to 20% in patients with symptomatic severe AS who underwent BAV. Object of our study are to evaluate short-term efficacy and safety outcome of BAV in symptomatic severe AS patients. Study design. Our study is single-center retrospective study. Population of symptomatic severe AS patients who have undergone BAV at Thammasat University Hospital between June 2018 and August 2021. Inclusion criteria were age 18 years and older, patients with severe AS who underwent BAV. Exclusion criteria were severe aortic regurgitation, pre-implantation BAV before TAVI, previous aortic valve surgery, and hypertrophic cardiomyopathy. Primary outcome of our study was 30-day all-cause mortality after BAV. Secondary outcome were rate of success procedure. Success procedure defined as mean aortic pressure gradient reduction more than 20%, or aortic valve area increased 0.1 to 0.2 centimeters square, and without severe aortic regurgitation. Periprocedural complication, acute hemodynamic result after BAV. All patients underwent a transthoracic echocardiographic study at Thammasat Heart Center before BAV to confirm diagnosis. Then we collecting retrospective data about baseline characteristics, echocardiographic parameter, laboratory data, procedural detail, hemodynamic parameters, 30-day mortality, complication, and success rate of BAV. Result, baseline clinical characteristic. Our study of 26 patients, the mean age was 80 years and 65% were women. The median STS score was 524, and functional class mainly were in New York Heart Association class 2 and 3. Indication for BAV were bridging procedure, 73%, palliative 15%, and cardiogenic shock 12%. The most common cause of AS in our study was calcific severe AS, 92%. Patients were classified according to flow state and mean aortic pressure gradient into flow group. 54% were normal flow, high gradient severe AS. Echocardiographic data show mean of peak aortic velocity was 4.3 meters per second. Median of mean transaortic pressure gradient was 42.5 millimeter of mercury. Mean of aortic valve area was 0.5 centimeters square. Mean of left ventricular ejection fraction was 53%. Primary outcome of our study show 30-day all-cause mortality after BAV was 15.38%, and not increased mortality at 3-month follow-up. The univariate association between baseline characteristic, echo parameter, hemodynamic parameter, and 30 days mortality show significant higher mortality rate in patients who had cardiogenic shock prior to BAV procedure, and patients with lower aortic valve area and lower creatinine clearance tend to increase mortality in 30 days. Secondary outcome, success rate of BAV in this study was 84.6%. Periprocedural complication was 19%. Periprocedural mortality was 3.85%. 3-month survival from death and heart failure was 80%. Periprocedural complication, no stroke complication was found in our study. Low rate of vascular complication, This may be the effect of combined ultrasound and fluoroscopic guided vascular access. Acute hemodynamic result after VAV demonstrate significant reduction of peak-to-peak trans-aortic pressure gradient and mean trans-aortic pressure gradient after VAV without severe AR. Conclusion, our study show 30-day all-cause mortality and freedom from heart failure was acceptable and consistent with 3-month follow-up. Our study also support a role of VAV as bridging or palliative procedure in high-risk patient with symptomatic severe AS regarding effective and safety of procedure. Thank you for your attention.
Thank you for the presentation. So now is open for discussion. So can we have some comments or advice from our panelists? Yes, please.
Dr. Salu's cycle is a good idea about the bridge for the before BAV. And what size of balloon do your team use, and what the critical point you think the BAV for the patient is quite important?
Pardon?
The size of the balloon is when you plan to do the BAV, the size of the balloon is 20 or 18 or 22, because the balloon size is larger and more complication. And what's the idea about choosing the correct size of the VAV balloon? The balloon size.
Yeah, I think Dr. Hayes, maybe you can give us an answer, but I think it's a very important question because the size would affect the complication rate, and how aggressive you are affect the efficacy and the complication rate. How do you choose the size of the balloon for your BAV patients?
Size of balloon.
Yeah. So what about comments from other our panelists? So do you do much BAV? Because nowadays we in our center we do much less BAV. We do TAVIs if they're suitable candidates, and sometimes it's difficult to gauge the aggressiveness, how to improve the hemodynamics, not to the point of having hemodynamic collapse. So can we have comments?
In my center, that's mostly we use the 18mm balloon. And there are 2 points we need to do the VAV. The first one is a very critical patient, and we do not have any idea about the annual size or any other comorbidity or any other condition. So we just do the VAV and let the condition stable. The second condition is when the patient is low flow, low pressure gradient aortic stenosis, because Taiwan is indicate that the insurance indicated in patient with high risk or the aortic valve less than 0.8 centimeter square. So if the patient have the low pressure gradient, the insurance have some idea about they won't pay the valve, so we do the VAV and see that the patient has some critical condition, and we can do that the patient recovered and applied for insurance.
Yeah, thank you. So this is a very nice abstract. At least we know that it works in some particular patients. It's a bridging therapy or for other non-cardiac surgery. So because of time limitation, we go straight to the third presentation by Dr. Mitsumasa Sudo from University Hospital Bonn, Germany. The topic is the impact of ANOVA nutrition index for predicting mortality in low intermediate surgical risk patients with TAVR. So Dr. Sudo, please.
This slide is my CY. TAVR has been established for symptomatic severe AS in high surgical risk patients. More recently, favorable outcomes were reported even in low intermediate risk patients. Previous reports showed that malnutrition increased mortality after TAVR. However, the association between nutrition status and clinical implication in low intermediate surgical risk patients undergoing TAVR is unclear. Recently, a simple calculable nutrition score, which can be calculated using triglyceride, total cholesterol, and body weight, was proposed. We investigate the clinical implication of the nutrition score in low intermediate surgical risk patients undergoing TAVR. Symptomatic severe AS who underwent TAVR at our hospital, low intermediate surgical risk between January 2016 and June 2019 were analyzed. Patients who lacked the TCB index before the TAVR were excluded. The low intermediate surgical risk was defined as Euro score 2 less than 9. TCB index was calculated as triglycerides multiplied by total cholesterol multiplied by body weight divided by 1000. ROC analysis was performed to assess the optimal predictive value of the TCB index for predicting 1-year all-cause mortality. Patients were stratified into high or low TCB index group based on the cutoff value. A total of 607 patients were analyzed in this study. 164 patients were low TCB index group and 443 patients were high TCB index group. This slide shows patients' characteristics. The low TCB index group was older and had a lower BMI than a higher TCB index group. Hemoglobin and albumin were lower, and eGFR was higher in the low TCB index. Among components of the TCB index, all parameters were lower in the low TCB index group. The slide shows Kaplan-Meier for 1-year all-cause mortality. The cumulative 1-year all-cause mortality was higher in the low TCB index group with compared to the high TCB index group. The Cox hazard model showed a low TCB index was associated with 1-year all-cause death. After adjustment, a low TCB index remained. Various nutrition scores, such as GNRI and CONUT score, have been proposed and were associated with worse outcome after TAVR. These scores reflect the patient's general condition, such as protein reserve, caloric depletion, or the immune status. Also, the scores are calculated with Hugh score. Their formula is not easy. The TCB index was proposed by Doi as a simple calculable nutrition. Moreover, the TCB index was related to mortality in coronary artery disease, acute myocardial infarction, and acute heart failure. In line with these previous reports, the low TCB index in the present study was associated with 1-year all-cause mortality. Body weight and total cholesterol and triglycerides are also components of other nutrition scores, which were associated with mortality after TAVR. Therefore, our findings might be not surprising. However, we have several limitations in this study. The cutoff value for malnutrition has not been established for the TCB index. Therefore, the cutoff value obtained in our study needed to be validated in the future. Total cholesterol and triglycerides are influenced by medications such as statin. In the previous study on coronary artery disease, low TCB index was an independent predictor for all-cause death even in patients using statin. However, user evaluation is needed. Thank you for your attention.
Thank you very much for your presentation. So do we have any questions? Yeah.
Can I have one question?
Yes.
Yep.
Thank you for your impressive presentation. And regarding the inclusion criteria, why did you exclude the high-risk surgical population from this analysis?
Yeah, thank you for your question. We have also a high risk score. So So all cohort analysis also low TCB index was higher mortality. However, in the recently, TAVR was expanded to the low or the low intermediate risk, surgical risk patients. So our study is so viable. Yeah.
Thank you. Thank you for your answer.
So can I have a question? So the clinical implication of the study is so the index, the lower the index, the poorer the prognosis. Is it logical to improve the TCB index before TAVI to improve the prognosis, or what is the message from the study that you just presented?
Thank you for your question. So I think so. Even in low to intermediate risk surgical risk patients, so our low malnutrition is lower survival. So we can, if possible, we can intervention to nutrition or before TAVR. This is an important message.
Yes, thank you. So I think you're right, because the low TCB score, they also will poor. I mean, they will have worse prognosis to undergo surgery because they have poor nutrition status, poor immune system. So maybe work out what is the best intervention for those patients, not to delay the procedure for too long, but improve the TCB a bit to improve the survival. So do we have any questions or comments from a panel? So if not, may I introduce Dr. Lee to introduce the next three speakers?
I have a question.
Oh, so please.
Yeah, I think that the very a lot of score about the nutrition and the phrase published from Japan. So, do you think fit is important? The phrase score or nutrition score to interpret the kind of low or intermediate AS patients?
Yeah, thank you for your question. So, yeah, is it too difficult to answer?
Yeah, I think both are important.
Yeah, so that would be another abstract to investigate on this. But okay, there are lots of scores, but we have to select which to take reference to carefully. But I think that they're good references to guide our treatment. So let's go for our next free talks.
My name is Mahmoud Abdeshafi, Clinical Research Fellow at Galway University Hospital, National University of Ireland, Galway. My presentation about quantitative and geographic assessment of aortic regurgitation, both 11 different types of TAVR devices, a multi-center bold analysis of 2600 valve. I didn't have any disclosure. Background: regurgitation following TAVR impact all-cause mortality. Thus far, no quantitative comparison of regurgitation by the same core lab has been performed among various commercially available transcatheter heart valves. We aim to compare quantitative and geographic aortic regurgitation of 11 different types of TAVR devices. This is our study population. Our study population included the first generation devices like Corval, and the most recent iteration, the Neo2. Also, it's included the technology from Far East. We have MyValve from India, and we have VitaFlow and Venus A from China. As we know, Lotus, Neo, and Corval and Sibian XT are not commercially available anymore. Yeah, this is a slide show how the analysis is done. We use CAST A valve of B-medical imaging for the analysis. Simply, we have a reference area in the ascending aorta, and we have the region of interest in the LVOT. As you see in this example of the color-coded image of the analysis, our cutoff point for moderate or severe was LVOT more than 17, for none or trace of LVOT ER less than 6, and if the LVOT ER equal or less than 6 or 17, it's mild. This is a slide show our main result. And here, all the valves ranked according to the percentage of moderate or severe ER. Roughly, we can divide the valves into 3 groups. The first group, if the moderate or severe equal or less than 5%, with the lowest valve have regurgitation is accurate neutral and lotus. The group with ER more than 10%, and this is included Sapien XT, accurate neo, venous A, and the core valve. And in between Sapien 3 and the Volute R. Here the comparison of the main LVOT ER after TAVR and the Lotus have the lowest mean LVOT ER. Limitation of our study. This was bold analysis of real-world patient undergoing TAVR. No randomization was performed, which may result in selection bias. The purpose of present analysis was to show the different regurgitation pattern among the valves. So no information regarding calcification, cuspidity, aortic annular size and shape, THV diameter, technique, and implantation depth. We presented only the data on the acute performance of the valves, and the long-term outcome is not available. Conclusion and take-home message. As we know, paravalvular regurgitation after TAVR is associated with poor outcome. We compared ER following TAVR in patients treated with different generation of THVs. The analysis was done by objective, reproducible, quantitative video densitometric aortography in academic setting, fully independent from industry. The sealing feature of the new generation devices are effective in reducing significant paravalvular regurgitation. However, the rate of mild paravalvular regurgitation is still prominent, which need more studies. This was a retrospective bold analysis. Thus, the result should be confirmed in prospective randomized head-to-head comparison between THVs. Thank you.
Thank you, Dr. Shafi, about your presentation. And any idea from the audience or the panelists?
I have one question.
Yeah, please.
Yeah. So thank you for your instructive presentation. Also, my question is that how did you differentiate paravalvular regurgitation from central valvular regurgitation?
Yeah, thank you for a good question. So actually, in 2D image, it's very difficult to differentiate the central regurgitation from the paravalvular regurgitation, but we are working now on the model from biplane aortography to reconstruct 3D model to differentiate between the paravalvular regurgitation and central regurgitation.
Okay, thanks.
And I have a question about your method. Do the blood pressure or other, such as when you use the beta-iodine contrast or the non-iodine contrast, will it affect the results or just about the same? Yeah,
so yes, we have there is protocol for the acquisition, and yes, there is the amount of contrast, the pressure of injection of the contrast, the position of the pigtail during the injection of the contrast. All of this should be according to the protocol and according to the preclinical study done in vitro, so the result will not be affected.
If any other have questions?
Yeah, we asked Professor Wojciechowski, do you have any advice or questions or comments?
I wonder how much does it correspond to the echo findings after the procedure, and perhaps you. I know that this is the retrospective data, but how well is it standardized in the routine?
Thank you. So this is the technique of video densitometry was validated in vitro against the regurgitation fraction in mock circulation. Also, it's validated against echo in multiple studies, from these studies, we have this cutoff point for LVOT more than 17%. Also, it's correlated with the outcome, but it's not shown in our study here. It shows that if the patient have more 17%, it's have more bad outcome.
I see. So thank you. So this is an interesting study, but nowadays we not just only rely on angiogram, and I would be happy to see if you have any standardized protocol, which is the best way to do the angiogram, because sometimes with the pigtail higher up or lower down, amount of contrast, pressure, different types of valves will affect the angiographic findings. Maybe if it is kind of can compare with echo as an adjudication, then maybe they even make the abstract more convincing or more representative to show which valve is better in terms of leaks.
Thank you. So,
yeah.
So, yeah, the team of Professor Strauss working on this technique more than 6 years ago. We have more than 25 publications which address all your question, and yeah, I will happy to send it. Thank you.
Great, thanks. So maybe let's move on to the next talk.
The next presenter is Rashid from Monash Heart and the Victorian Heart Institute, Australia. His topic is the impact of hypoattenuated deep lead thickening on hemodynamic valve deterioration following transcatheter aortic valve replacement. And welcome, Rashid.
Hi, thank you very much for this opportunity. So I'm Dr. Rashid from Australia, and my talk today is on the impact of CT-defined leaflet thrombosis in predicting structural valve deterioration following transcatheter aortic valve replacement. So essentially, CT can accurately predict and diagnose the presence of leaflet thrombosis on CT following TAVI with a prevalence of up to 17 to 30%. The hallmark feature of leaflet thrombosis on CT is the presence of HALT, or hypoattenuated leaflet thickening of the bioprosthetic leaflets, if you can view the images on the right, which is classically taking the appearance of a meniscus sign on the aortic surface of the bioprosthetic leaflets. We have previously published in JACC on how different prosthesis factors may impact on the development of leaflet thrombosis. Different deployment of TAVI valves can lead to stasis or blood stasis at the aortic cusps, or abnormal transvalvular flow, and all of these can potentially impact on the development of leaflet thrombosis. There's also been a lot more interest in how leaflet thrombosis can impact on bioprosthetic leaflet function. This is a study that was presented from the CT sub-study of the Partner 3 trial, which was examining the impact of TAVI in low-risk patients. And here what you can see is that at short-term follow-up, leaflet thrombosis may actually cause structural valve deterioration. There's a signal of this, which shows that there is high risk of partially and immobile restricted leaflets following those who had HALT, and also a signal of increased transvalvular gradients, But a limitation of this study was that it only had a short-term follow-up of up to 1 year. So therefore, in our study, our aim was to determine the impact of HALT on structural valve deterioration at a medium-term follow-up, and also to determine any HALT characteristic that may predict structural valve deterioration. We had 186 patients who had prospective CTs at a median of 6 weeks following TAVI. And from these CT scans, we had 2 blinded CT readers assessed for the presence of HALT, defined as biprosthetic hypoattenuation. All patients received dual antiplatelet therapy for 6 months, followed by aspirin alone, unless anticoagulation therapy was required. But this was based on the previous recommendation. There's been an updated recommendation to recommend only aspirin alone from the recent studies. From the CT scans, we also assessed the CT characteristics of the HALT, defined as the cumulative HALT area, which was the largest HALT area at short axis view on the left, and also the cumulative HALT depth, the largest depth of HALT on long axis view. This is the protocol that we had. Essentially, all patients received a clinical review and an echocardiogram at pre-discharge at 4 to 6 weeks and annually thereafter. And the echoes were assessed by an echocardiologist blinded to the HALT status, looking for the presence of structural valve deterioration seen here in the bottom right, defined as mean gradient of more than 20 with an increase of more than 10 from baseline, an increase in reduction in Doppler valve index of 0.1, and also new intraprosthetic moderate to severe regurgitation as per the current ESC and VARC guidelines. And these patients were followed up to 3 years in this study. And what we found was that the prevalence of leaflet thrombosis was 17.7%, which is consistent with the current literature data. But interestingly, the prevalence of structural valve deterioration was at 8.6% in 16 cases, where 2 of these patients required repeat valve intervention, 5 required commencement of oral anticoagulation therapy, and the remaining patient were just closely monitored. But patients that developed HALT were more likely to develop structural valve deterioration compared to those without HALT. And as alluded earlier on, higher rates of repeat valve replacement. We also found that on our echocardiographic data, that patients that developed HALT were also associated with increased transprosthetic gradient throughout each time point in our follow-up. And as you can see here, it continues to rise at 3-year follow-up. And using our HALT characteristics, and this is the other novel finding that we found, was that a cumulative HALT depth threshold of 2.4 millimeters and a HALT area threshold of 28 millimeters squared accurately predict structural valve deterioration on ROC analysis. This discussion point leads to the fact that HALT may be a precursor of overt valve thrombosis or clinical valve thrombosis, where it is a continuum of different types of clinical manifestation, where HALT may lead to reduced leaflet motion from increasing thrombus burden, which, if left untreated, may potentially lead to severe valve dysfunction. The other novel finding in our study was that certain HALT characteristics may also predict structural valve deterioration. We know that HALT is a dynamic process, and we found that those that had a depth of more than 2.4 millimeters or HALT area of more than 28 millimeters squared led to structural valve deterioration, and potentially, if not closely monitored, may lead to overt valve thrombosis. These are limitations and conclusion. This is a single center study, which is hypothesis generating, and we did not have any core lab adjudication. But I'd like to conclude by highlighting that HALT was associated with structural valve deterioration and repeat valve activation in our study, and HALT depth and area were strong predictors of structural valve deterioration and may be used for future parameters. CT following TAVI may determine patients at risk of structural valve deterioration and valve reintervention. Thank you very much for your time.
Thank you, Professor Rashid, about the amazing topic, and the topic open for discussion. And anyone have idea about the hypoattenuation leaflet thrombosis?
Oh, it seems to be a dynamic process. So the thrombosis may be resolved over time, or new thrombosis may show up. So time frame to evaluate the HALT in CT. Let's say it will be used in the routine practice.
I think that's an excellent question. As you highlight, it is a dynamic process that potentially HALT may actually regress or it may actually get worse. What the finding from our study showed was that there's a certain cutoff where the HALT may actually progress or get worse, which was a 2.4 millimeters on HALT area and 28 millimeters squared on HALT area and HALT depth. So potentially, if it reaches that threshold, then HALT may actually progress. So I think this is an important parameter we should find. And as you rightly said, that HALT may actually regress over time, but it may actually get worse. So what we could do is that by having an earlier CT scan, yet 4 to 6 weeks where we had, and also in the CT sub-study in the Partner 3 trial, you can actually highlight patients at risk of structural valve deterioration and closely monitor these patients. And I think using the most recent studies, they've been using a parameter of between 4 to 12 weeks. 12 weeks was where the Galileo CT sub-study was using. And potentially this early follow-up for these patients is important. And let's not forget that ACC and ESC now recommend closely monitoring of patients following biprosthetic valve replacements.
Yes, I have a question about the timing of the CT scan and the protocol of the CT scan, because the HALT may be affected by systolic phase or diastolic phase. And what is your idea about you doing the measurement in diastolic phase or systolic phase? And we have a lot of patients have the increasing pressure gradient, and we do the CAT scan and show HALT. And our routine procedure is check the echo, and if any problem, we check the CT scan. And any idea about choosing the CT first, and then followed by echo, or you just use the CT and then the result effect of treatment using the echo, follow the result, or repeat the CT scan?
All right, thank you for that question. So I might answer the second part first. The current guidelines do not recommend routine CTs on all patients, but the current guidelines have now shifted towards actually thinking about CT in patients with new increased transvalvular gradients or those with new aortic regurgitation. So these are patients that we should actually think about doing CTs, and actually the guidelines now recommend considering CT scans to look for HALT or leaflet thrombosis. With regards to our protocol, the current guidelines actually recommend the assessment of HALT to be performed in diastole and then also in systole to look for a condition called restricted leaflet motion or realm. And this is where the amount of HALT is large enough that it's actually affecting on the systolic motion. And in our study, and also in previous studies, what they've shown is HALT is usually very minimal effect, but once you start having reduced leaflet motion from higher HALT burden, that impacts an opening. And this may be a precursor of increased transvalvular gradients. So I think there's a lot of things that we still need to know about this, but I think what we hope we've done, we've actually laid out some foundations for future studies and also introduced some novel parameters to be used, hopefully clinically, but this needs to be assessed in further studies.
Any comment or the question from the study? Okay, then we move to the next topic. The next presenter is Chogo from Xinjiang Hospital, China. And his topic is the left atrial appendage occurred with the Watchman device, peri-procedural outcome from the prospective multicenter record registry. Welcome, Chogo.
So esteemed panelists, ladies and gentlemen, greetings. I'm Chogo from Xinjiang Hospital of Xi'an, China. And on behalf of Professor Ling Tao and all the record investigators, I would like to present you the record registry. I have no conflict of interest to declare, and it is projected that in 2050, there will be like 8 to 10 million AF patients over 60 years old. And currently, the oral anticoagulation is the standard of care in patients with non-valvular atrial fibrillation. However, there are multiple groups of patients in whom an alternative strategy is required, including the reasons of contradictions to anticoagulants, side effects, adherence, and quality of life issues. Randomized data has confirmed that LAAO is non-inferior compared to anticoagulants, and current guidelines have recommended LAO for AF patients who have contradictions or are unsuitable for long-term anticoagulations. East Asians are one of the most commonest ethnic group with a population in excess of 1.5 billion. The East Asians have a unique risk-benefit trade-off in a management of stroke prevention, and with reduced antithrombotic benefits and an increased bleeding risk with antithrombotic therapies, particularly high risk of intracranial bleeding. And this phenomenon is known as the East Asian paradox. Consequently, the East Asian population with AF might have a greater benefit from non-pharmacological strategy such as LAAO. However, clinical outcomes from previous studies did not include East Asian populations such as Chinese, Korean, Japanese, or other ethnic group. How well these trials can be applicable in the East Asian population is still questionable. And here, we conducted the RECORD registry, which is a single-arm prospective observational real-world study conducted in 39 Chinese centers from April 2019 to October 2020. 3,096 Chinese AF patients with a intent for LAO procedures were consecutively enrolled. 99.5 had a successful Watchman implantation, and 30-day follow-up was completed in 98.9%. And 1-year follow-up have been recently completed, and we hope we can present in further conferences and journals. Here is the baseline characteristic. The mean age of this population is 69 plus minus 8. 57 were male, 23 had a previous diabetes, and around 46 had a previous stroke. The Hasley, the chest-to-vest score was 4.0, and Hasley score was 2.4. Compared with other previous LAO RCTs or registries, the RECORD population had a numerically similar ischemic and bleeding risk. The procedural characteristic, recapture, there's 8.3 patient had a recapture before the final release. Device was implanted 1.04 per patient. The most frequently used device is 27, 30, that's around 30% of patients. Complete sealing was achieved in around 90% patient. General anesthesia, localized anesthesia were 58 and 41 respectively. TE guidance was used in 81%, and the rest were by fluoroscopy or ICE. Interestingly, we observe a lot of combined procedure, which is one-stage procedure of LAAO and radiofrequency ablation or side ablation. That's around 42%. Clinical events at 30 days were talking about death, stroke, and systemic embolism. That's 0.5%, and any bleeding was around 1.7%. By the way, the procedure success was achieving 97.9% of the population. Procedure complication occurred in 1.2%. And compared with other studies, the RECORD study, which enrolled primarily the East Asian population, had similar death, stroke, and periprocedural complications. Here we talk about the impact of procedural considerations on clinical outcomes. As you can see here, whether if there is a combined procedure or not had no significant impact on the death, stroke, and system embolism at 30 days. Also, the type of anesthesia, general or localized, the type of imaging modality also had no significant impact on the death, stroke, and SE at 30 days. But if we're looking at the experience of operators, we use the cutoff point of 40 cases annually according to center. The procedure success was significantly higher in the centers performing cases above 40 compared to those below 40. And also, those experienced center was associated with lower rate of any life-threatening or major bleeding at 30 days. So we would like to propose a threshold of 40 cases per year for defining a experienced center. And we believe that once this level of skill and competence is achieved and maintained, it is difficult to further improve on the rate of procedure success. Here is the take-home message. There was a high procedure success rate of 97.9 for implanting the Watchman device percutaneously in this large cohort of Chinese patients. At 30 days, the rate of composite endpoint of death, stroke, and systemic embolism was 0.5%. Intra-procedural variation with the type of anesthesia, whether a generalized or localized, modality of the guidance, TE, ICE, or fluoroscopy, or isolated versus combination procedures had no significant impact on procedural success or thrombotic and bleeding event at 30 days. Procedure success and the rate of life-threatening or major bleeding at 30 days were significantly lower in centers in performing more than 40 cases per year compared to those below 40. And thank you for your attention. That will be all. Thank you.
Thank you, Dr. Chow Ko. And the topic open for the questions and any idea about the LA occurred by using Watchman.
Yes, I have one question. So thank you for your nice presentation. I'm very surprised with the very high volume and very high success rate using the Watchman, previous generation Watchman device. So my question is about the antithrombotic therapy. So how do you use antithrombotic therapy in Chinese? Because I think that in the US protocols, we have to use OAC plus aspirin for 45 days and adapt for 6 months and aspirin monotherapy for lifelong. So how do you use in Chinese?
A very interesting question and very intriguing question, actually. Because of the limits of time, we didn't put how we use the DAPT or anticoagulation after the LAO. But it's still in our manuscript, this is one part of the most important and part need to be emphasized. So according to ESC guideline 2020, they recommended a indefinite aspirin, and for the first 45 days, they required anticoagulation, and after 45 days, up to 6 months, DAT might be used, or anticoagulation is also recommended. But in the East Asian population, which is quite unique, we observed that around 40% of patients were taking the Nuvac monotherapy right after the implantation of LAO, which is absolutely not in line with all the guidelines. But interestingly, we found that using this kind of medication, we observe a numerically lower rate of complications. And now we have reached a 1-year outcome, and whether this will be maintained at 1 year is still, we are still analyzing, and we still don't have the data. But I think it might be different for the East Asian population compared to the white or Caucasian population in terms of the post-procedural medications. Thank you.
Thank you.
So I have a question. So would usually the next question is, how would this patient behave after some time, for example, 6 months and 1 year, because we want to know the bleeding events and also the stroke rate. And this is really amazing, because I could note that half of the patient is undergoing local anesthesia, and some patients have fluoroscopic guide with this acute success. That is really amazing. And is it this record registry would have ongoing assessment with TEs and also a collection of data on stroke and bleeding to know the long-term outcome for this patient. I mean, this is a very important proof to the world that it works even better. I mean, the value of LAO is much even more worthwhile to perform in Asian population because of the background you mentioned.
Yeah, I think if the patient had a follow-up with the data available for us to collect about CT or TE or any other imaging mortality, we would definitely going to record, but sadly, not all patients had a routine visit at 1 year. And but in our next trial, RECORD 2, which is a randomized control trial, we have been recently approved by Boston Scientific. We're going to have a very strict surveillance about the patient who had the LAO at 1 year. We're going to have a MRI at baseline at 12 months, and also a CT surveillance. Regarding the 1 year result, the bleeding rate were 8%, talking about the Munich consensus, that's the overall bleeding rate, 8%. And also astonishingly, the death, stroke, and embolism rate were 4.5. So that's not so low, but still not significant, not numerically so higher than the other trials. 4.5.
Yeah. So thank you very much. I think we had a very good discussion today with all educational abstracts and cover all different aspects of structural heart, including valves, occluders. And thank you once again for our co-moderator, Dr. Lee, all the panelists, Dr. Ko, Dr. Kubo, Professor Wojciechowski, and all the speakers and all the participants. And stay healthy and enjoy TCTAP 2022. Thank you for joining.